Pain that persists for months after an operation is healed is a recognized condition with its own name. It is called chronic post-surgical pain, and it is not a sign that you are recovering badly. One line of research has looked at what predicts it, and among the findings is that sleep disturbance, measured before surgery, is associated with pain afterward. That last point is worth sitting with because it says something useful. Some of the risk is identifiable in advance. Here is what the evidence actually is. A systematic review and meta-analysis examined whether sleep disturbances and sleep disorders influence the presence and intensity of chronic post-surgical pain. It included cohort studies of adults in which sleep was assessed before surgery, and pain or opioid use was measured at least 3 months afterward. 18 studies were included in a narrative synthesis, and 12 in the meta-analysis itself. The result was that sleep disturbances and disorders were significantly related to chronic post-surgical pain with a small effect size. The correlation was 0.13. Now the caveats, and these belong in the headline, not the footnotes. The authors rated the certainty of the evidence as low because of risk of bias and heterogeneity between the studies. The effect size is small. So this is a real signal, but it is not a large one in anyone presenting it. As a major lever is overstating it. I would rather you hear that from me than discover it later. The subgroup findings are equally worth knowing because they tell you where the association did and did not appear. It held in studies that measured pain intensity, but not in those that measured simply whether pain was present or absent. It held in patients undergoing total knee arthroplasty and other surgeries, but it did not hold in patients having breast cancer surgery, and it did not hold in total hip arthroplasty. So this is not a uniform effect across every operation. A meta-regression also found that the length of follow-up was positively associated with the overall estimate. The author's own conclusion is measured and it is actionable. Presurgical sleep disturbances and disorders should be evaluated in order to detect patients at risk for chronic post-surgical pain. Read that carefully. It is a screening recommendation. It is not a promise that fixing sleep prevents pain. Practically, that means two things. If you are heading toward a planned operation and you already sleep badly, it is a reasonable thing to raise beforehand rather than after. It costs you a conversation. And if you are already months past surgery, with pain that has not resolved, sleep is worth addressing as part of the picture rather than dismissed as a consequence of the pain. The relationship runs in both directions. Then there is the larger question, which is the one that actually moves treatment forward. Persistent pain after surgery deserves the same question as any other chronic pain. What structure is generating it? Because the possibilities are genuinely different from one another. Scar and nerve entrapment is one problem. An untreated pain generator that predated the operation is a second problem. Central sensitization is a third. They are different problems with different treatments. And the label chronic post-surgical pain does not by itself tell you which one you are dealing with. At the Padda Institute, where previous spine surgeries involved, the relevant pages are failed, back surgery syndrome, and epidural lysis of adhesions, also called epiduroplasty. Nerve-directed options include nerve blocks, hydrodissection, and peripheral nerve stimulation. And the behavioral component is delivered in-house through counseling for chronic pain. Let me answer the questions that come up every time. How long does pain have to last to count as chronic post-surgical pain? The research standard used in this literature measures outcomes at least 3 months after the operation. Persistent pain past that point warrants evaluation rather than more waiting. Does poor sleep before surgery really predict pain afterward? There is a statistically significant association, but the effect size is small, and the authors rated the certainty of evidence as low because of bias and variation between studies. It is a reason to screen. It is not a reason to alarm. Does this apply to every kind of operation? No. The association was found in total knee arthroplasty and other surgeries, but not in breast cancer surgery or total hip arthroplasty. It is not uniform, and evaluation is individual. My surgeon says the operation was successful. So why do I still hurt? Because a technically successful operation and a resolved pain problem are two different outcomes. The pain may arise from scar or nerve involvement from a generator that predated the surgery, or from central sensitization. And what can be done now if it has already been months? The same diagnostic logic still applies. Identify what is generating the pain and treat that. Options include nerve blocks and peripheral nerve stimulation. To have persistent pain after surgery evaluated, request an appointment at painmd.tv/appointment. Call 314-481-5000 or text 314-886-5902. We have 2 locations, 4477 Woodson Road, Suite 100 in Street Lewis, and 12174 Natural Bridge Road in Bridgeton. You do not need a referral, and you do not need to be an existing patient.